Yes. Good morning, everyone. My name is Stacy Doris, and I'm with QSource, and I want to welcome everyone that's here in the room with us on a rainy day in Memphis, and also virtually attending across the state. We appreciate your participation this morning in our HIPAA event. We are really excited to offer this event this morning. It really grew out of some work that was being conducted over the past year within our local communities, and really trying to improve the quality of care across multiple care settings. And so the need really was specifically, how do we understand the HIPAA regulations about what we can do as we transfer patients across our communities, our local communities of healthcare. So whether it's understanding the HIPAA regulations, that's vitally important at a corporate level down to really the frontline staff that are treating these patients. We just are honored to have our expert HIPAA guest speaker, Janelle Burns, with us here today to really provide us with some valuable information, and also let you all as participants ask those questions that you're experiencing on a daily basis, so that we can all be on the same page as we care for these patients in our local communities. So without further ado, let me introduce Janelle, and then we will let her get started. I will mention that there are we will have a Q&A session at the end, but if you do have questions during her presentation that you don't want to forget till the end, you may chat them. There's a text feature, and then there's also an email feature. So go ahead and submit those as we go through the presentation if you would like, or you may wait till the end. So let me introduce Ms. Janelle. She is currently in private practice of law and provides HIPAA consulting services. Previously, she served as the Corporate Privacy and Security Officer at Baptist Memorial Healthcare here in Memphis, and she oversaw compliance with patient privacy laws for 14 hospitals and approximately 150 physician practices located in Tennessee, Mississippi, and Arkansas. That's a small feat. Ms. Burns began her career with Baptist in 2002 and received her Doctor of Jurisprudence and a certificate in health law from the University of Tulsa College of Law in 1999. So thank you for being here.
Thank you.
Oh. Don't want to run over. Here we go.
Good morning, y'all. Thank you for being here. Let me mic up just real quick. There we go. Okay. Well, thank you all for having me out. I'm so happy to be here, and thank you for coming out today. And thank you to all of our friends who are streaming across the state of Tennessee. Really excited that you're interested in this topic. It's been my primary focus of my professional career the last 17 years, and I love talking about it. But sometimes people don't get quite as excited as I do. So I'm glad that y'all are here and that y'all are streaming. Just a quick general disclaimer, because I'm using, there we go. General disclaimer, it's today is an educational purpose, so I can't give you specific legal advice and everything. No attorney-client privilege, but we'll treat everything as a hypothetical. So everything is hypothetically speaking if this were to happen. And we won't, worry about what's actually happening, but we'll go with hypotheticals. And just realize all fact patterns are unique. And so someone today may ask a question, and you're like, oh, I have something very similar. The analysis, all basic analysis is the same, but there can always be some very specific details that can turn the analysis. So just keep that in mind, that there can be similarities, but also all fact patterns are unique and different. So sometimes we'll have some different things that can change the analysis a bit. So just an overview of what we're going to do today. So we're going to go over to how to analyze a scenario. And so the purpose of today is to teach you to fish. So when you get situations that come up and you're like, okay, what are we supposed to do? It's to help you go, okay, we're going to go back to basics and we're going to work through the analysis step by step to kind of help us figure out what our options are for either sharing information or getting information, depending upon which end of the disclosure you're on. We're going to talk about the types of permitted disclosures. When QSource asked me to come speak, they said that was one of the major things is we spend a lot of time with HIPAA telling people what they can't do. We don't spend a lot of time telling people what they can do and what information they can share and how to share. And so we're going to really focus today on permitted disclosures and what you can share and how you can share it. We're going to take a little break. Then we're going to talk about application to some specific topic areas. Some people already had sent in questions, and so I went ahead and tried to prepare some slides to be responsive to those questions. And then after we finish those, we have more free time that we can tackle any other questions that you all want to send in today. I do have a note on here. I do presume that you have a basic working knowledge of HIPAA, that you probably have had some sort of HIPAA training, but that doesn't mean that you've covered every single detail. So if I say something and you're like, I have no idea what she's talking about, please don't hesitate to interrupt me and ask, send in a question, and so that we can answer it. I always say the only stupid question is the one that goes unasked. So just ask. It's no problem. Okay, so starting point. Definitions matter, and this is true no matter which law you're trying to analyze. Every law will start with a set of definitions that apply to that law. And sometimes it can get confusing because sometimes different laws will use the same terms, but within those laws the terms mean different things. So it's really important to always go back to your definitions and understand for the law that you're trying to analyze what those definitions say in that law. Always go back to basics. Look for what the basic guiding principles are. In HIPAA, the basic guiding principle is that the individual, the patient, the client, has control over where their information is shared. That's our basic guiding principle that we start with, and then there are permitted disclosures that follow from that. Make no assumptions. You can't skip steps. This is analyzing these types of situations is just like when you did math in school and the teacher always made you write out every step, and you're like, why do I have to write out that 2 + 2 is 4? Everyone knows that. Well, it's just part of the process to make sure that you're not skipping things. So the same as in analysis. And then we're going to focus on the types of allowable disclosures. I know we hear a lot about what's not allowed, but today we're going to focus on what is allowed. So analyzing, oops, I'm sorry. How do I go back?
I'm sorry. Go ahead.
That's okay. If I go, I'm going to go back. I think I ended up going forward. To the game, Guess Who. So a lot of this, what we find in HIPAA is that it is sort of like a game of Guess Who. The first thing you have to figure out is who are all the players. So we're wanting, someone's wanting to get information. Well, what role do they play in the healthcare spectrum? And who are they trying to get information from? And what role does that person play? And part of it, trying to figure out who, is asking then the questions we have on the next slide. We're going to get there. Is who am I and who are you? Do I provide healthcare services? Do you provide healthcare services? Do I bill insurance? Do you bill insurance? Am I a social services agency? Am I a hospital? Am I a hospital system? Do I participate in an organized healthcare arrangement? These are all things that we have to know about ourselves and about the entity that we're seeking to get information from in order to understand who's allowed to share and which ways the information can flow. So those are always just important questions to make sure that we ask. So whenever we're doing a disclosure, we're going to have a sender and we're going to have a recipient. And so we need to analyze, so who's doing the sending? Is it a covered entity? Is it a healthcare provider who's not a covered entity? Is it someone else? And then who are they sending it to? Are they sending it to another covered entity, a healthcare provider that's not a covered entity, a social services agency, someone who falls into the other category? And what's the purpose of the disclosure? How is the entity that's receiving the information going to use that information? And does the receiving entity have a relationship with the patient? So those are the basic questions we have to answer as part of doing our analysis. So a lot of the premise is that most of the time it's going to be the covered entity who's going to have the most information about a patient, and then it's going to be either another covered entity, a non-covered healthcare provider, a social services agency, or some other third party that's trying to get information from the covered entity about the patient. And so we're going to focus on, and keep in mind that what the law covers are covered entities, and we're going to go through definitions here in just a few minutes. But I have in here this section of law, the 45 CFR 164.506 subsection C, that covers what types of information a covered entity may disclose. And depending upon the purpose, they can disclose information to different types of providers. So for treatment purposes, it can go to a healthcare provider. And so that does not have to be a covered entity healthcare provider. That can just be a healthcare provider. And we're going to talk about the differences between the two in a couple slides. For payment purposes, they may disclose to, a covered entity may disclose to another covered entity or to a non-covered healthcare provider. For healthcare operations purposes, it's to another covered entity. So here we start getting more specific again, where it needs to be another covered entity, not just a healthcare provider. And then if you participated in an organized healthcare arrangement, what we call an OCA, although I used to work with people who always said, oh, you mean that okra thing? Sure, the okra thing. We can go with that. Okra, OCA, close enough. You know, we're in the South. It all works. You know, and that's for specific purposes. So, so those are things that may disclose, and that's one of the key points that I think we do have to remember. So what HIPAA says is, for all the purposes we just covered, the covered entity may disclose. That's permissive, not mandatory. And so sometimes if you're going to a covered entity and you're trying to get information from the covered entity, you have to keep in mind and take it from the you catch more flies with honey approach, that, you know, you're asking them to make a disclosure that they may make, but they're not necessarily required to make. So what I always find helpful is, keep in mind why it is that you're asking, and to the extent that you can demonstrate that why you're asking for the information is in the best interest of the patient, because we're trying to provide continuity of care, we're trying to coordinate benefits, coordinate managed care, that what we're trying to do is to benefit the patient, or that somehow it's improving the entire healthcare ecosystem, that goes a lot further than, well, I need this information. Okay, well, but why do you need the information? So, that's important. Explain your entity that you represent, and explain where in this analysis your entity fits. The better that you can explain that you are allowed to get the information and point to the rules that say you're allowed to get to the information, you're going to be in a much better position when you're making requests. It will go a long ways. So let's talk about the difference between a covered entity and a healthcare provider. So a covered entity, as it's defined by the regulations, is a health plan, a healthcare clearinghouse, or a healthcare provider who transmits any health information in electronic form in connection with a transaction covered by HIPAA. So then our next question becomes, well, what's a transaction covered by HIPAA? And so we list those below, and it's the transmission of information between two parties to carry out financial or administrative activities related to healthcare. And then the definition goes on to list some very specific things that constitute a transaction. And so that would be healthcare claims, health payment and remittance advice, coordination of benefits, healthcare claims status, and then we get some things that are more related to health plans, which are enrollment, disenrollment, eligibility for a health plan, premiums, and then we get into some more care things, which is referral, certification, and authorization, healthcare claims attachments, electronic funds transfer. it's the types of things that you would think, anything that has to do with money and a provider getting paid for the services that were provided that's through an electronic format. HIPAA has another section called standard transactions, which if you're in the business of billing, you know, the idea was to move everyone, has a national provider number so that everyone's using, all health plans are using the same provider number for each provider, and then the standard transactions and code sets that we use for claims. So that all relates back to HIPAA. Okay. So a healthcare provider, there's a definition of that. It's not very helpful. And so what I've done is tried to go through and give you in a couple slides just more of a breakdown. So it's a very long definition. Well, it's complicated in that it's a provider of services, and if you go to these other two sections that are referenced in the U.S. Code, you will get multiple pages of the types of services that they're talking about. I find it more instructive just to look to the definition of healthcare that's provided in HIPAA, which is basically any preventative, diagnostic, therapeutic, rehabilitative, maintenance, or palliative care, or we have counseling, service, assessment, or procedure that relates to the physical or mental condition of the individual, or is the sale or dispensing of a drug, device, equipment, or other item in accordance with a prescription. So we have our covered entity, which is regulated by HIPAA, and then we have a healthcare provider. And a lot of people ask, well, how can you be a healthcare provider and not engage in the standard transactions that would make you a covered entity? And I list in the bullet points below. Basically, you could be paid in cash. You could have the type of office where your patients pay cash. It could be that you don't have to bill insurance because the healthcare services you provide are paid for by grant money, perhaps from the federal government, where you're issued a chunk of money to provide services to patients. In some instances, it could be that you provide a service to, say, a hospital, and the hospital pays you directly, and you're not actually billing the patient's insurance. Not as common, but possible. So that's how you can be a covered or a healthcare provider, but not a covered entity. And keep in mind, when we're talking about HIPAA, the scope only regulates covered entities. So HIPAA says what covered entities may and may not do. If you're not a covered entity, you don't have to follow the rules of HIPAA. You have a lot broader discretion. Now, there may be other state laws, there may be other laws that govern the type of professional service that you do. If you're a counselor, there can be ethics issues, but in terms of HIPAA only governs covered entities. So let's talk about the allowable disclosure. So the first section that we had looked at was for treatment purposes, and that's where, so on our left here, we have an entity disclosing PHI, and that's a covered entity, again, because we're talking about the covered entity making the disclosure. Now, the receiving entity can be a healthcare provider, either a covered entity healthcare provider or a non-covered entity healthcare provider. But there does need, does there need to be a relationship with the patient? Yes. Otherwise, it's not going to be for treatment purposes if they're both not being seen by the patient's not being seen by both. So there we have that one. Then our next is for payment purposes. Now we start spreading out a little bit more. So we have the entity disclosing the PHI again, the covered entity. Who's receiving it? Well, it could be a healthcare provider, either a covered entity healthcare provider or a non-covered entity healthcare provider. Could be the health plan because they're receiving the claim and they need to process it for payment. Or it could be a healthcare clearinghouse. And a clearinghouse is essentially, we haven't talked about that yet. I wasn't expecting really any on the call, but a clearinghouse is going to be an entity that takes information in a standard or non-standard format and then translates the information into a language that it's usually for payment processing. They take information from their provider, roll it around, and take it into something that the health plan can work with. They're definitely in the space, but we don't have as many issues with them in terms of disclosures. Okay. Now, for healthcare operations, things start getting a little bit trickier now. So we have the covered entity doing the disclosure. The receiving entity could be, change here, we only have covered entity healthcare providers. We do not have the non-covered entity healthcare provider. I guess the regulations made the assumption that the non-covered entity healthcare provider wouldn't have the same types of healthcare operations needs that covered entities would have. We have the health plan, and then again we have the healthcare clearinghouse. We have a lot more restrictions when we get into healthcare operations. So the information can only be disclosed for either subpart 1 or subpart 2 of the definition of healthcare operations, or fraud and abuse detection and compliance. So we're more limited once we get into healthcare operations. And the rules are very specific that both patients must have or had a relationship with the patient. So, what are these limited healthcare operations for which we could disclose information? The definition is found at 45 CFR section 164.501, and the subsection 1 is for conducting quality assessment and improvement activities, including outcomes evaluation and development of clinical guidelines, patient safety activities, population-based activities related to improving healthcare or reducing healthcare costs, protocol development, case management and care coordination, contacting of healthcare providers or patients with information about treatment alternatives, and other related functions that do not include treatment. So the types of operations that we do tend to see with larger organizations, so that's subsection 1. Definition, healthcare operations subsection 2 is reviewing the competence or qualifications of healthcare professionals. Health plan performance, conducting training programs where students, trainees, or other practitioners are trained. We have accreditation, certification, licensing, and credentialing activities. So let's think about this. Let's take kind of a common example for this one to kind of try to bring it home for us. So we have a hospital who's a covered entity, and say we have an orthopedic surgeon who wants privileges at the hospital in order to perform surgery there. So the hospital, as part of its credentialing activities, is going to ask the surgeon for information about number of surgeries performed, if there were any, have been any lawsuits or any claims against that surgeon, and they're going to ask for some, possibly patient-specific information if there have been any claims, so they can evaluate whether or not they want to give that physician privileges within their hospital. So we're talking about a sharing of PHI from one covered entity to another covered entity. So in this case, it's actually going to be going from the surgeon, who's a covered entity, because he's billing for services, filing insurance, sharing PHI with the hospital for the purpose of the hospital's ability to review and make sure that they want to credential that physician to provide services within their hospital. So that's an example of a permissible disclosure in the flow of information from point A to point B, having a purpose, and so in relationship with the patient. So we have that. Now, we also have a carve-out, which is fraud and abuse. So fraud and abuse is actually covered. The definition of healthcare operations actually has, I believe, 5 or 6. I believe it's 5 subparts to that definition. It is a lengthy definition. Fraud and abuse detection is actually included in subsection 4 of the definition of healthcare operations. But for the purposes of sharing information, because the government has an interest in preventing fraud and abuse of the healthcare system, they also included this as an allowable disclosure between covered entities. So there is a carve-out for fraud and abuse. Okay, our next section is the OKRA, our favorite topic, the organized healthcare arrangement. And so people always ask, well, how do I know if I'm part of an OCA? And so that kind of some common questions that you can ask yourself that'll help clue you in is, do you provide healthcare services in a hospital but yet you're not an employee of the hospital? So you go into the hospital and you see patients but yet you're not a hospital employee. So that could make you a physician going in, that could make you a some sort of therapist if the hospital outsources that. And does the hospital use a joint notice of privacy practices that lists the types of service that you provide or the type of entity that you represent in that joint notice? So if you're a covered entity, you're required to provide a notice of privacy practices to patients that explains how you use their information. In order to prevent every physician that comes into a hospital from having to bring their own notice of privacy practices with them, there is this concept of an OCA was developed whereby the hospital can provide, and it's supposed to be in conjunction with the physicians on medical staff, but for the most part the hospital develops it, the physicians approve it, and the hospital gives it out, where there's a joint notice of privacy practices that says this notice covers this hospital, all of the employees, the staff, volunteers, any students working under our supervision, but also the following types of entities. And it's going to be basically any provider that comes into the hospital to provide services to the patients in the hospital. And while they're in the hospital, they're going to follow the terms of this joint notice. Now, it could also be a physician that has a separate practice where they also see patients in their office. And in the practice, the physician may have his or her own notice of privacy practices that covers that office. But when they're in the hospital, they're covered by the joint notice. And that's allowed because of this concept of an OCA, which is the idea that we have multiple providers providing care in one setting. Or another sub-definition for that is that we have a healthcare provider that has multiple locations. So do you have offices or locations that provide the exact same notice? Do you have one privacy officer that covers all locations? So you could have perhaps a physician's office that has 3 different locations, but they coordinate among each other because you probably have the same group of 3 to 5 physicians that are covering all 3 offices. And so there's coordination between those offices, and so that could be an organized healthcare arrangement. So allowable disclosures for an organized healthcare arrangement, it has to be activities related to the organized healthcare arrangement. So it's from the covered entities participating to other covered entities participating, and it has to be for joint activities. So things such as quality assessment and improvement activities, utilization review, common things that are a theme for the entire organized healthcare arrangement, not just 1 or 2 participants solely within the organization. Okay. Any questions so far from the group? Okay. Other permitted disclosures. So we've covered one section of permitted disclosures. Now we're going to talk about another section. So in section 45 CFR 164.512, which is a very lengthy section, it talks about the types of disclosures that a covered entity is permitted to make without obtaining an authorization from the patient or giving the patient an opportunity to agree or object to the use or disclosure. I listed here some common examples to help kind of guide us in terms of what that section's talking about. There are actually about 12 different categories, and some of them are more straightforward than others. So I listed the ones that are more straightforward. So we have public health activities. So public health reporting. Covered entities are actually healthcare providers, covered or non-covered, will be required by usually state law to report communicable diseases to the county health department. So that is going to be a permitted disclosure. Child abuse, neglect, and reporting. Usually it's mandated that certain well, actually all healthcare providers, and then even some individuals that aren't healthcare providers, such as teachers, are going to be required to report suspected child abuse to either law enforcement or Department of Children's and Family Services. Reporting crime on premises. This is a specific section under the law enforcement section. The rules for law enforcement, which is why I say that you have to read each of these sections very carefully, is very lengthy, and it depends upon the type of crime that you're reporting, who the victim is, whether the patient is a victim or a suspected perpetrator of a crime, if the person being sought is a fugitive, whether the person is actually in the hospital bed. And each one of those has very specific rules about what can be released to law enforcement and what can't be released. Sometimes law enforcement's required to put certain requests in writing and to make certain written assertions about how the information will and won't be used. But reporting crime on premises, so if someone comes into your facility and shoots someone else there on your premises, that is definitely a permitted disclosure. That's all the law enforcement disclosures, that's the most straightforward and the easiest one to work through. Coroners and medical examiners, that's permitted to share information for them from the covered entities so that they can do their job. Same with funeral directors. And then organ procurement organizations, obviously with a focus on trying to facilitate organ procurement, we definitely want to permit those disclosures, so that's specifically included in that section. Like I said, that section also includes disclosures for like administrative and legal purposes. Each one of those sections, it's important if you've get a request to look at those sections and be very thoughtful about making sure you're following the rules for disclosures in section 512. Other ways to obtain PHI. So sometimes we have things that just fall into the other category. And I suspect we're going to have a few of those types of questions come up today. When I was visiting with the QSource team a couple days ago, and we were talking about the types of people and groups that would be attending today, and some of the really neat programs and innovative programs that we're seeing in Memphis, and trying to figure out how to help those programs in terms of sharing of information. You have to keep in mind that all laws, and not just HIPAA, don't usually keep up with changes as fast as we would like. Particularly technology is another area where the law always lags behind where the technology has taken us. It's just how it is. And so sometimes you're going to find yourself in situations where there's not going to be a specific portion of the regulations that directly relate to the type of program that you're working for, that you're trying to share information with. And so we go back to basics and we see if we can fit it into one of those boxes, but sometimes things just don't fit. And then we have to look at it and say, okay, well, what are our options? What can we do? And so I gave you an example of something I actually had worked with in the past, and really what we ended up doing, because we couldn't find any other box to put it in, but it's a good program, and the covered entity wanted to make the disclosure, but they just needed to figure out how they could do it. So it was a situation where the American Red Cross had a grant to help pay for transportation to get patients to their chemotherapy treatments. But they wanted to be able to, as part of, I'm sure, their grant reporting, to track the patients who are receiving services, to be able to justify that the service, for future grant years was being well utilized, was being utilized appropriately. So they were trying to get information from the hospital to make sure the patients were coming, they had come for their services, the transportation had been provided, and they wanted to know the date and time that the patient would need return services back to the hospital for their next chemotherapy. And so, we did the analysis. Red Cross is not a healthcare provider. They were helping to facilitate getting patients to treatment, but they themselves are not a healthcare provider. They're not a health plan. There is a very lengthy definition, once again in the regulations, about what constitutes a health plan, and it is much more along the lines of what we think of. It's the Blue Cross, the Blue Shields, the Uniteds, the Cignas, the Aetnas of the world, where there's a plan and someone pays a premium, whether it's the employer or the individual, and services are provided and reimbursement is sought. So they were not a health plan. And so we were trying to figure out, well, how could they obtain information? And finally what we came up with was, well, we can just get the patients to sign an authorization that says, the hospital can release information, and you do need to be specific what information is being sought. If it's demographic information, if it's more than demographics, maybe it's diagnosis too, to share that information, and then the patient signs it. And the most important part is that it does have to meet the requirements of HIPAA. And HIPAA is very specific about what elements have to be included in an authorization. You have to say who's doing the disclosing, who the information is going to be disclosed to, the purpose of the disclosure, and what information. It has to be done in a meaningful fashion that the patient can have a reasonable expectation and can understand what information is going to be shared. Is there an expiration date? How long is the disclosure good for? The patient signs and dates it, but there also has to be some statements that we would not have seen on any sort of authorization prior to HIPAA, about the patient having the right to revoke that authorization if they choose to do so, that once the information has been disclosed to the recipient, if the recipient is not a HIPAA covered entity, they could redisclose it. And so you have to make sure that you've included all those things on the authorization to make sure it's a valid authorization. But sometimes that is the best way to be able to accomplish your goal. I did want to make sure everyone is aware, the Office for Civil Rights, which is the federal administrative agency that enforces HIPAA, maintains a website, and it actually is a wealth of information. And one of the things that I find particularly helpful when I'm looking up issues is to go to their FAQs for professionals. They have their website broken down into if you're a patient, a client, and you have questions about how HIPAA works for you, there's a section for that. There's a section if you're a patient and you want to file a complaint. And then there's the section for professionals. And the professionals really does have really good information. The FAQs are grouped by categories, by topic categories. You can also do keyword searches. And so I highly recommend that if you haven't been out to this site, it's definitely worth a visit. Okay, we're actually a little ahead of schedule, so we'll go ahead and keep working through. Do you have any questions to date?
So, as you indicated with the changing landscape
Mm-hmm.
in healthcare and the regulations are probably not keeping up with that.
Hold on one second.
We're going to bring you a microphone, sorry.
We need to get the mic because before we do anything, no one's going to be able to hear you online.
Yeah. Okay. Online people, please hold for just a second.
Yeah, you're good.
All right. Okay, great. As you indicated with the changing landscape in healthcare and the various up-and-coming organizations may not fit within a box, where does a physician hospital-owned organization fit, and where they have accountable care organization agreements with various health plans and providers?
They're going to be definitely a covered entity, and also an OCA. They're going to be an organized healthcare arrangement. That's one of the subsections I didn't go over in the definition of an OCA, is when you have accountable care organizations, and you have the idea is that you have multiple parties all participating together in some sort of larger than the individual pieces, but working together. So they're going to be a covered entity, and they're going to be an organized healthcare arrangement.
Thank you.
Okay, any other questions? Okay, well,
Actually,
maybe.
Actually, you have one that's come via text. It says a mental health provider here.
Mm-hmm.
What if you have a provider from another hospital that you're not aware that a client has seen by calls you and says they need a copy of a report from a crisis provider, but you do not have a release? I felt like they should have had a release, but the other company did not agree. We did finally get the release, but I wanted to make sure I was correct in what I thought. Does
Okay.
that make sense?
It does actually, yes.
Okay.
So we have a mental health provider, I'm going to summarize, who has been seeing a patient, and now they're getting a call from maybe a crisis type provider who the patient has gone to, and the crisis provider is contacting the regular provider of mental health services and asking for them to release information to them. And so the question is, may the main provider release to the crisis type provider? And they may. The one thing, it gets a little trickier for mental health, and I know mental health professionals are more sensitive, and rightfully so, to release of health information about their clients. From a HIPAA perspective, they're covered because it's for treatment purposes, and you're relying on the assertions of another healthcare provider. Now, what I would encourage always to happen is verify that is a real health provider out there. And so sometimes that can be accomplished by just, Googling them real quick to make sure, checking the phone number that they're calling from. Oftentimes you're going to need a few minutes to check your files, so asking them for a name and a callback number, and then doing, a quick search to verify, whitepages.com or something else, or their website, that is a phone number associated with that provider. If they don't have any sort of release, oftentimes mental health providers, when they see a new client, will ask that client to sign a release, and it doesn't need to be a HIPAA compliant release, because they actually are under HIPAA, would be allowed to share without any sort of release, but just for an extra layer of comfort that the client is aware that both of these providers are going to be sharing information. Often they'll just have the client sign a real simple release saying it's okay for the two providers to talk to one another. Now, in this instance, if we do have the second provider is crisis, and they're asserting that they need the information for emergency treatment type purposes, once again, it's going to be covered by HIPAA. What I would encourage just for the primary provider to make a note of is the representation that it was for emergency treatment purposes. And you want to be responsive, but ultimately it's up to the provider to also use their best professional judgment as to what's in their client's best interest. And thankfully in this case it was the primary provider, so they'll have the most information about the client as to diagnosis, kind of what their current status has been, medications or no medications, to kind of make some decisions. But from a HIPAA standpoint, they're covered because it's treatment. Okay. Any other questions? Okay. I might go through a couple more slides and topic areas before we take a break. That way so we're taking a break at 10. Is that correct? Okay. Okay. So specific topic areas that we've gotten some earlier questions about, and the first one is mental health, which is definitely a prime area where we see always significant need. Generally, and I pulled the this slide the information directly from an FAQ that was out on the OCR website. I thought they did a nice job of summarizing, so I'm just going to cut and paste what they said onto this slide. But it's generally HIPAA does not limit disclosures of PHI between healthcare providers for treatment, case management, or care coordination. The one exception is that the individual clients do need to authorize if there's going to be any sharing of the psychotherapy session notes for treatment purposes, which I don't know how often those actually get shared. The idea behind therapy notes is usually that the provider who's making the note is making the note for themselves so that they can remember what was said, interactions, responses to questions. It's usually those notes are for the provider. They are, and to meet the definition, they have to be maintained separately from the medical record. So usually those types of notes about anything that a client told them during a session is usually kept in the mental health provider's office, locked up, and separate from the general note, which is going to be what we see down here in the second bullet point, what we would typically put in a medical record, which is going to be, any medication, prescription monitoring, counseling sessions, start, stop times, dates, modalities and frequency of treatment furnished, results of clinical tests, and then summaries of diagnosis, functional status, treatment plan, symptoms, prognosis, progression to date. That's what we usually see in the medical record, and that type of information is under HIPAA treated the same as any information about a broken bone. It's just considered part of the overall picture of the person's health. Now on the next slide, in Tennessee, I did want to point out, and if you work in the mental health profession, this is not going to be news to you. Tennessee, and I think several other states, many other states, do have some privilege statutes where it essentially establishes the same type of privilege you have between attorney and client to conversations between the client and their mental health provider. And I gave 2 of the statutes here. I actually think when I researched this previously, I think there are actually 4 or 5 on point, because it's broken down to the type of mental health provider that you are. There's a different, each one had their own section. So the 2 I just grabbed real quickly: the licensed psychologist, the psychological examiner, the senior psychological examiner, and the certified psychological assistant are covered by Tennessee Code Annotated 6311-213 that talks about conversations are placed, confidential communications are placed on the same level as the attorney-client privilege. Now in 6322-114, which covers our licensed marital and family therapists, our licensed professional counselors, our certified clinical pastoral therapists, basically says the same information. However, that one is probably a little newer in that it talks about there is an exception for mandatory child abuse reports. And most therapists, what I've seen in documents that I've reviewed, have actually made mention when they're talking, giving their clients information about confidentiality. It's, things that you say to me are confidential, except that if you tell me that you've been abusing a child, I am required to report that. And that's pretty commonplace. And like I said, these are just 2 of the Tennessee statutes, but the others that are specific to other types of mental health providers, all basically it's very similar language. Okay. Oops. And then another area that's also very popular is the substance use disorders and release of PHI under that. So, and this is an area that I see a lot of confusion in, because we always talk about substance use disorders. I think a lot of people assume that the rules, the special rules about always having a special authorization for substance use, any sort of reference even to substance use disorder, applies to them, and it really doesn't. It's only if you're a provider under Part 2. And people are like, well, how do I know if I'm a provider under Part 2? And it's like, well, are you the Betty Ford Clinic? Or are you an A&D unit within a hospital? And basically what it says in the regulations is, do you provide treatment for substance use disorder, and do you hold yourself out as being a provider of treatment for substance use disorders? And so usually in your advertising, usually not in the name, although the names are usually very kind, and Park Place and Lakeview, and we always have very kind names around places, but it's like, do you hold yourself out and you actually provide? And are you a specialized unit within a hospital versus the emergency room? So if a patient comes to the emergency room, with symptoms, maybe they have alcohol poisoning, and that's related to a substance use disorder, the fact that there are notes made in the emergency room record that, in terms of the patient's blood alcohol level, and then conversations either with the patient or family member about the fact that the patient does have an alcohol use disorder, that's not specially protected because the emergency room is not a Part 2 provider. So when it comes to releasing that information, it doesn't require this special release and all the rules that go along with a Part 2 provider releasing that type of information. Then it's just part of a medical record. Now, we do always have in every hospital's authorization form, there's usually, or release form, there's going to be some mention just to alert people of the fact that there may be information about drug, alcohol use, sexually transmitted infections, cancer. We list all these different things just to make the patients aware. But the only people that have to follow the special rules, and those were, I believe, recently updated about in the last 2 years, because I've seen a lot of presentations taking place about some of the rule changes with and how people are defined if you are a Part 2 provider and you're trying to release information. But most people don't actually fall under that. If you did happen to fall under Part 2, you do have to comply with both Part 2 and HIPAA. And a lot of the presentations I've seen have been, okay, how do we comply with both of these? But from what I understand, basically if you comply with Part 2 first, which tends to be the most restrictive, that should help you almost automatically comply with HIPAA. But if there's anything else that isn't covered, then you do still have to comply with HIPAA. SAMHSA does have a lengthy FAQ out on their website talking about the interplay between HIPAA and Part 2 and the types of things that Part 2 providers need to do if they're looking at releasing patient information. And so if this affects you, I would encourage you to go out to that website and just read through it. It's set up in an FAQ website or a format, and it's actually, I think, very helpful for reading. Okay. Maybe we'll go through another slide or so. Getting information for infection control. So this was an issue that was submitted. So we had a question about, it was a broader question. I put some more specifics in. But if a paramedic is bitten by a patient, what options are available for obtaining the bloodborne disease status of the patient in order to guide the treatment of the paramedic? And really there are multiple routes because this is a major issue. We don't want to, increase any spread of disease. So we would have two basic routes that we could go down. One is just the simple treatment option. Sharing of information between the patient or the physician treating the patient and the physician treating the paramedic. Two medical professionals sharing information. Treatment is usually the broadest available disclosure route, and so just the sharing of information for the purposes of treatment. But other options, if for some reason that became a barrier, would be involving the Department of Health. As an entity that is publicly is charged by state law with investigating and controlling the spread of disease, it would be to notify them and essentially use them as the middle person to help facilitate the sharing of information, conducting the investigation. And then the other option that's also included under public health are OSHA regulations. And as part of fulfilling the ambulance company's obligations to fulfill its duties under OSHA, to make sure that the paramedic is offered appropriate treatment and testing would be as part of the OSHA regulations, to use that as the basis for obtaining information from the treating physician. So multiple routes there. That's an area where it shouldn't be a problem to obtain information, because it really is in the best interest of the paramedic / patient at this point to become so that we know if any prophylaxis treatment needs to be started. Okay, I think we have time for one more. Re-release of information. So this is a little bit tangential, but it is a really hot topic among health information management professionals. And it's how and when can a healthcare provider, whether that's a covered entity healthcare provider or a non-covered entity healthcare provider, release information that was obtained from another healthcare provider. So for example, a patient is seeing their primary care physician for chronic sinus infections. And finally, the primary care physician says, I really think you need to go see a specialist. And so refers the patient to an ENT. And along with the referral, sends over portion of the record that relates to the number of times that the primary care doctor has treated the patient for sinus infections, which antibiotics they've used, if there's anything else that they've tried, any decongestants, sends that over with the patient to the ENT. Then the ENT says, maybe they want to share that information with, maybe they end up outsourcing the patient to see a special type of surgeon. And so it's like, can we disclose what the primary care provider shared with us to the surgeon who's going to be actually doing the surgery on the patient's sinuses? And for treatment purposes, yes. I mean, you're under HIPAA, you're allowed to do that, because it's all seen as facilitating the treatment and the care coordination for that patient. Historically, in the past, there wasn't a lot of re-release, and a lot of times what health information professionals would say is, well, I don't want to release something that I didn't create. This isn't mine to release. But what we're seeing is, in order to try to better coordinate the care and make sure everyone has the full picture of the patient, we've moved toward the re-release. Now, in terms of how each provider defines its own medical record, we have a couple things. So in HIPAA, we have what's called the designated record set, and that is where each provider has to write down what parts of the record or what types of records they consider to be their designated record set. And that's anything that you've used medical or financial in terms of your treatment of the patient. And that's what the patient then has access to under their right of access and right to request amendment if there are any errors in the record. So we have that issue. We also oftentimes, every office will have what they consider their official medical record, is what they release. And so, for instance, they may only include final lab results in their official medical record. They may not include preliminaries, for instance. But every office can set their own practice. We try to get those to be as coordinated as possible. The other things we try to see is, has the provider incorporated that other record that they've received into their own record? And with electronic medical records, we're seeing this more and more, and there are different ways to do it. Some people will, there'll be an entire file of records that's like outside received records, and that's where any record that you've received about that patient is filed in like its own file sitting over here. But we're also starting to see electronic medical record systems that will actually go out and proactively, if you have scheduled a patient to come in for a visit, it will actually go out, especially if it's an EMR that participates with any sort of regional health information organization, health information exchange. It'll actually go out and pull information from other providers and bring it into the EMR, so it's already there when the patient comes in to see the provider. And so it's definitely an important area that we're looking at, because one of the things that we want to make sure is that we're keeping our medical records clean. And we always say, you know, garbage in, garbage out. So if we're not making sure that the information that we've pulled in is about the right patient, you know, that we have met our patient identifiers, you know, we can end up with a polluted medical record where we have wrong information, and that's something we definitely want to avoid. So to the extent that you're working with your HIM departments, or you are an HIM, this is a very big and important topic. Okay, I see we are at 10:02. I think let's go ahead and take our 10-minute break for now, and then we'll be back in 10 minutes. So if you have any questions that you would like to send in, please go ahead and send them in the next 10 minutes, and then we will try to answer those in the next hour. Thank you. Just tell me when I'm ready.
You're good.
Good? Okay. And we're back for our next exciting episode of HIPAA. Okay, so welcome back, everyone. Thanks for staying with us. I think I have one more substantive slide that I wanted to cover. It was a question that was previously submitted about social media, and if I read the question correctly, had to do with employees taking cell phone maybe pictures of patients and posting them on social media. And so just wanted to remind everyone, disclosure of PHI on social media by an employee of a covered entity could subject both the employee and the covered entity to HIPAA enforcement actions, and also there is always the possibility of a civil lawsuit for breach of privacy. I know we always like to mention, HIPAA doesn't offer specific remedies for a patient other than just to file a complaint with the Office for Civil Rights, but that does not prevent patients from engaging a lawyer for a civil lawsuit against the entity for breach of privacy. So there are going to be still opportunities for that. The other thing that's come into play, the last changes to HIPAA that came about in 2013 actually also authorized state attorney generals to pursue enforcement actions within their state against covered entities who have violated HIPAA. And I have not seen a ton of those, but there have been some where state attorney generals have looked at that as a means to go after entities. It also, the statute allows the state attorney generals to recover money and money for the cost of pursuing the action. So it's something that a state attorney general could do that would bring in money, and they could also recoup the money for the cost of their attorneys in the state pursuing the action. So that is something to keep in mind. So in order to combat this problem, all covered entities should have a sanctions policy in place. That is one of the required policies by the regulations. And that policy should address if an employee accesses, uses, or discloses PHI in a way that's not permitted by HIPAA. Another thing that we've seen a couple times and that has gotten entities into trouble is even though covered entities should not be placing anything on social media, sometimes patients are taking to social media to complain about treatment that they've received at a hospital or at a doctor's office. You cannot use their PHI and respond back. And I know a lot of times people have a knee-jerk reaction and think, oh no, they're going to cause other patients to think that we're a bad, medical practice because they're saying things that aren't true about us. And kind of the natural inclinations to get on there and find, well, actually, that's not right. This is what really happened. And you just can't do that. Or if you do that, you need to be extremely careful that you're not releasing anything about that patient or the care that they received when you do that. And it's really hard for people because they're like, well, they already put all their information out there. They already put why they were there at the doctor's office, what tests were run. It's like, well, yes, but that was their information to disclose. It's not the covered entities, which takes us back to our very first premise, which is HIPAA is about giving the patient control over their information, the patient deciding where the information gets shared. So always go back and think about our basic premise and really stay off social media. And if you have employees that get on social media and they violate it, you need to follow your sanctions policy, whatever that may be. Because should you get a complaint filed against you by the patient with OCR, the very first thing OCR is going to ask you when they send you their list of requested information is for a copy of your sanctions policy, and then they want to know what you did to the employee or the employees who were involved, because they're looking to see if you followed your sanctions policy. So you need to have one, and you need to be able to show that you've been consistent in how you followed it. So those were our previously submitted questions. So now we have time, and we have plenty of time for any additional questions that anyone wants to ask. So I think we have one that we were going to read out, and then anything else that the group here wants to ask, and if anyone online wants to ask something, please go ahead and send it in.
Yes, we have 36 people watching on the stream, so I've encouraged them to text and to submit their questions. We did have one that came in that said, what if there's no text or next of kin or durable power of attorney, and the patient has early dementia? Who can the information be released to?
And this gets really complicated. We see this, unfortunately too often in hospital settings where we have patients and maybe they've just outlived all of their relatives. Maybe they had a very small family to start with. In those situations, we really have to look to the provider to make some determinations as to what the patient is capable of understanding, not understanding. Obviously, in those situations, sometimes patients have good days and bad days. And so what we usually have to try to do is on their good days, try to ascertain from them, is there anyone that could help them in their care? And it could even be, it doesn't have to be a family member. Sometimes it's a neighbor. We've seen several situations where it was the next door neighbor, someone who lived down the street that just had been checking on the patient, once a day or, a couple times a week. They would swing by and make sure they were still okay and try to get the contact information from the patient and say, well, is it okay if we involve them in your care? There will be times, though, when we have a patient, once they progress to a certain degree where they can no longer actively participate in their care, even on good days. And at that point, Tennessee does offer an option. It's the surrogate decision maker, which is something you could use both before they progress to the point they can't participate and also after. Ideally, if before on a good day, you would want them to designate someone. If they're to the point where they no longer have decision-making capacity to tell us who they want involved in care, there are provisions where a physician can be appointed to make decisions for the patient. We can also always go to and that there's some steps on the form that has to be completed where we have a second physician who's not affiliated with the first physician review the case, make sure that they feel like the physician who's being proposed to make decisions, that they agree with that. We also, if you're in a hospital setting, have the opportunity to do like a medical ethics consult, where the medical ethics committee will meet and discuss the case and come up with what they think is ethically the appropriate thing to do for the patient. So there are options out there. Sometimes those options don't really exist until you get into an acute care setting. There are some, if sometimes the hospital could, it's not common, but have to go to the court and request that the court appoint some sort of state-provided guardian for the patient to help make decisions for the rest of their life. So there are options out there, and it's just a matter of exploring what those are. Obviously, we always want to try, to the extent that a patient's having a good day, get the patient's involvement, get some ideas from them, but sometimes by the time they're in an acute setting, that point has passed, and then we just have to go with the physician, surrogate decision maker, medical ethics, or look at the court approach to have the court appoint a guardian or a conservator for them. Any other questions?
Does HIPAA extend or end at death, and what are the rules that apply? Excellent question.
Excellent question. So there have been some changes to this over time. Essentially, the latest is it extends 50 years beyond death. So in theory, and I'll also go back though to the fact that may disclose is our key word. So a facility can always choose to have a policy that preserves the patient's right of privacy longer than HIPAA. The same way that states can offer additional protections above and beyond what HIPAA does, individual facilities can choose to extend it longer. But the current, we could look up the section if the questioner needs it, but essentially it's been detailed out to be 50 years beyond the patient's death.
And this is just me personally.
Uh-huh.
If you're doing some educational training
Uh-huh.
and you have a speaker who is using autopsy photos,
Mm-hmm.
what authorizations do they need, or do they need them since the exhibit is deceased?
Mm-hmm. And so where that's going to depend is to the extent, because what we're talking about releasing is PHI. So is it still identifiable? And in some situations, if it is a diseased liver, it may just look like 50,000 other diseased livers. And so as long as there's no identifiers anywhere on what is being displayed, it is not identifiable. But there can be situations where an X-ray can show such a distinctive type of injury that it could be recognizable, particularly if, everything's fact specific, but say that you had someone who had, during hunting season, an arrow shot into their head, but your question was autopsy, but say they, say it was in the local news, mm-hmm. and it was kind of well known, and I mean sometimes even stories like that might make the national news, that oh my gosh, this person lived for 6 months with this arrow stuck in the top of their head. To that it can be identifiable, and it can be identifiable to people who are aware of the situation. The other thing to piggyback on that is there is a statute in Tennessee called the Colby-Stansbury Act, and it's a situation where a young man was killed in a car accident, and I may not have all the facts exactly right, so if I don't, forgive me, but the general premise is he was killed in a car accident, and photos of the accident, like the car itself and the damage, was taken to the local high school as part of an education series. And I don't know if it had to do with drinking and driving or seatbelt usage. It had to do with some sort of education for the local high school kids. And unbeknownst to the presenters, I think it was a cousin, but there was some sort of relative of the young man who had been killed who was in the classroom and became extremely distraught and upset at viewing the pictures of the relative's car accident. And so we ended up in Tennessee with the Colby-Stansbury Act, which basically says anytime you're going to use pictures or such for education, you have to take affirmative steps to protect the dignity of the deceased. And so it's to be very thoughtful in terms of how you're portraying. And I know a lot of times and I'm sure the intentions were good, a lot of times with high schoolers, we're trying to get them to make good decisions, always wear your seatbelt, don't text and drive, keep your hands on the wheel at 2 and 10, all the things that we all should be doing, but we're trying to get them to do it. And so sometimes we give them very graphic illustrations of what can happen if you don't do that, but we have to make sure that we're not doing it with something that relates to someone else, and something that, especially if it's a local education, can be problematic. So just keep in mind that if you do that type of education, you do have to comply with the Colby-Stansbury Act. Any other questions coming in? Okay, I'll open it up to the group in here for questions. Oh, and we're going to bring the microphone to you so we can make sure everyone hears you.
So hypothetically,
Yes, hypothetically, my favorite word.
an accountable care organization is engaged with a health plan.
Uh-huh.
And the health plan chooses or indicates that they cannot share sensitive condition information that is come from claims.
Mm-hmm.
Is that true, or are they protected or prevented from sharing substance use disorder information, mental health services information with the accountable care organization?
Interesting. So, so the accountable care organization is going to use it for what purpose?
Quality improvement, care coordination, cost management.
Mm-hmm. So we'd go back to I don't think I can go back slide-wise, but we would go back to, so we're going to be healthcare operations.
Uh-huh.
Okay. So we're going to look at healthcare operations. We're going to look at what our requirements are. So it's has to be one covered entity to another covered entity. So health plan's a covered entity. And so what we have to figure out is the accountable care organization a covered entity? Well, it's really an organized healthcare arrangement.
Exactly.
It's an organized healthcare arrangement.
Mm-hmm.
And so under organized healthcare arrangement, what we would have to see, I'm just trying to get to that picture, is it has to be for activities of the entire organized healthcare arrangement. So we have a kind of a mixing of uses, which is where it gets tricky. So we're looking at patient specific, I'm assuming.
Yes.
Okay. So, but the health plan would have gotten the sensitive information from the providers.
Correct.
Okay. So, but we don't have the providers sending to other providers. We have the providers. I'm trying to figure out if we could, rather than, I guess, what's the goal of having the plan release the information versus provider to provider or provider to care manager?
Because you're looking at an entire population.
Okay, so we're looking at population health activities. And so then we have to look into, and you're looking at population health, then we're kind of back into the healthcare operations section. So it does become, at that point, the one time when you get the pass on minimum necessary is for treatment. But since we've moved from treatment to healthcare operations, then we're going to have to think about minimum necessary. And so then I think the question becomes, for the activities and for a population, so if we're wanting to do a program to help those who have a diagnosis of substance use disorder, we're going to be looking at then, like, what's the minimum necessary? And so,
but you may, at the end result, you may want to influence treatment patterns.
Mm-hmm. Yeah. So you're looking at, so for this population, we've maybe done a comparison of those who received once a week counseling versus twice a week counseling, just to make it something simple and basic. And we're looking at, did the twice a week counseling have a better end result than the once a week counseling? And if so, then we want to kind of start making that the standard mode of treatment. At that point, what I would encourage is really to sit down with, to me, is sort of the role of the privacy officer for the accountable care organization is to look at, okay, so what do we really need to know in order to analyze the situation? And part of it's going to be a negotiation probably with the health plan. It's interesting you see it's the health plan, hypothetically, that doesn't want to share the information. In my past experience, they were the ones that were kind of, information was flowing everywhere. It's usually, so it may be that, and is the goal to include the health plan because they're the easiest ones to run the report.
Well, they are
and
the
aggregate.
ones that provide the information.
Okay. Well, I'm just wondering if working with the individual providers would, or groups of providers.
Well, the providers are part of that network.
Mm-hmm. Yeah, no, I think it can be done. It's going to be permitted, but it's a matter of probably negotiating out with the plan what's the minimum necessary to accomplish the analysis that you're trying to get to, in terms of, is this better than this? You know, which of these options gives us the best end result? And it's a balance sharing, and that it does get complicated with when you have all these groups come together. But if it's for, I mean, the accountable care organization itself should be an organized healthcare arrangement because it's part of a larger group. So really it should be the all sharing of information for the overall activities of the organized healthcare arrangement.
Right.
So it's developing a protocol for everyone, because I'm assuming then once the protocol is developed, then the providers, that would be suggested as the best, the suggested approach for if you have a patient that has this diagnosis, the recommended approach is X, Y, and Z, and that would be encouraged.
Right, and so you do see those regulations or those metrics out there that do pertain to treatment protocols. However, if you don't have the information to analyze whether those treatment protocols are being or you're meeting your metrics, that becomes very difficult to manage that population or to change the way that care is provided.
Well, and I'll throw out one other thought too, which is at some points you actually start getting into almost what falls into research. And so for research, you essentially have two routes. One would be where the patient authorizes the use of their information, which is not what I see happening with these types of studies. That's more like in a clinical trial where you have a patient who's going to participate in a new drug. And so they read a very lengthy informed consent, they sign an authorization. The other is where the patient often doesn't even know their information is being used for research, but where the protocol would be reviewed by an institutional review board. And so most large hospitals have them, or they're also private ones that you can pay, and they're like professional review boards, and they go through and they review your protocol for, do you have appropriate protections in place for the information? Do you have all these different mechanisms? Have you met this? And then they grant approval. So it almost could be, to the extent you may be looking at some sort of almost a research protocol to go through and do an analysis, which then now you still end up with the plan is part of you though. I was going to say, you still end up with the plan might have some resistancy, but that does give them comfort that it has been reviewed by an outside party and they have said you have the appropriate protections in place, especially if you have, say, a particular department or subunit within the organization that they're the ones that do all the analytics and do the reviews to show that it's protected. But I mean, one of the things you can point out is unless you have Part 2 participants within your accountable care organization, and if you do, then that does throw off the analysis, because then they do have to make sure they're complying with the Part 2, and it has some specific requirements about when you release information, that there has to be like a written notice that goes with it that tells the recipient that they cannot release the information, to make sure you're following all of those regulations. But assuming you don't have Part 2, then I think you point out the fact that, you know, the OCR says that just having a diagnosis of a substance use disorder or a mental health disorder has the same HIPAA protections as the fact that you have diabetes or chronic migraines. It's all the same.
Right. Thank you.
Any other questions? Does anything come in? Oh, hey.
One here in-house.
Oh, okay. We have an in-house question. Yeah.
I have actually a couple of questions that
Okay.
are related to content you've already discussed.
Uh-huh.
One is on the research question.
Mhm.
Do you have recommendations on modifying the notice of privacy practices to allow for research? Not clinical trials so much as just reviews of data, PHI, looking for trends, things like that.
Yeah, I mean, it's really just talking about the fact, so your notice of privacy practices, if you're going to do research, yeah, you have to modify it to include that in there. Put your updated date up in the corner so they know when it's been updated. And really, there's no specific required language. It just has to be enough that explains to the person how the information is going to be used. And so the most practical advice I would give is look at hospital notices that are publicly available out on the internet and look at the language you like the best. is the fastest and simplest way, but it's usually very innocuous language. You know, we may participate in research. You know, your data will be protected. It'll be reviewed to make sure it meets, you know, requirements and stuff like that.
And then my other question has to do with, on the social media slide, you discussed a sanctions policy.
Mm-hmm.
Do you have recommendations on what that might look like, or where good sources of information on that?
Yeah, so I'm trying to think. I don't know that I've seen any good. There will be some organizations that have policies out available on the web. I don't believe that OCR has a standard one. I think you have to decide. To me, it's sort of like any of your employment policies. Decide what is acceptable to you and based on risk. What I have done in policies I've worked on is I do try to lay out categories of behavior. And a couple of thought processes on why I do that, but one is from a HIPAA enforcement in terms of your, you know, fines and potential penalties. The OCR is looking at, was it a willful act? Was it a negligent act? Was it inadvertent, or was it malicious? And malicious is the highest level, and that also qualifies you for the greatest fines and penalties. And so when we say malicious, and they define it in the regulations, it's basically when you're trying to take a patient's protected health information and use it for personal gain. So, you know, any sort of identity theft where, you know, you have someone who's stealing, you know, patients' names, addresses, dates of birth, and social security numbers, and then going out and opening a bunch of credit cards up in their name and then spending, you know, limiting them out as fast as they can and getting all that merchandise. You know, that was for personal gain. We've seen some situations that actually made it into the news and were pursued by OCR. There was one, it was actually over in Arkansas, where it was a divorce custody battle where the employee at a facility, and I can't remember which way it went, if it was the wife or the husband, but anyway, took health information from the hospital record about their soon-to-be ex-spouse and tried to bribe them with the fact that they would disclose that in the divorce in order to influence the custody that they were trying to work out. So that's using it for personal gain. So to me, that's the highest level, and those would definitely be situations where that person probably does not need to be employed with you. They pose a great liability. Then you have the ones where it's, did the person, should the person have known better? It's like using common sense. Should you have known that you shouldn't have done this? And then it's, depending upon what your situation is, whether you have already established appeals processes or whether you have at-will employment and you can just terminate the person on the spot, whether you think it's something that they can learn from and still go on to be a good productive employee, then you look at doing retraining, making them go through some classes and sit down. So most places do some sort of retraining, re-education for non-malicious, non-willful acts. But if it's something you should have known better, you'd been trained, you'd been told, or you were trying to somehow personally benefit from doing what you did, then those usually are terminable actions, is what we normally see. But you also have to work within whatever your existing framework is for discipline. I would just kind of blend it into that too. And you may already have a discipline policy that you can tie it into without having to start from scratch.
Okay, another question. What can a behavioral health facility release to primary care to a primary care physician without a release being signed by the patient?
If it's for treatment purposes, anything that the behavioral health provider feels comfortable releasing that they think is relevant to the treatment purposes. Now, what we talked about before is, the stuff about, the fact that they do have a diagnosis, they come for counseling once a week, their progress plan is to continue counseling for another 30 days, 6 months, 30 days, whatever that might be. Basic information, if it's for treatment purposes, you're covered under HIPAA. So I think it probably depends upon the provider, their relationship with that primary care physician, their relationship with the patient/client as to what the client feels comfortable with. It depends on the situation. So in an emergency situation where you don't have a chance to discuss with the client, then I think you have to go with your best professional judgment as to what the provider needs to know to treat the patient at that moment in time. If it's something where the patient's not scheduled to report back to that primary care provider for a checkup for 6 months, it would actually give you an opportunity to discuss with the patient what they want shared and don't want shared. But for treatment purposes under HIPAA, for HIPAA purposes, you're covered.
That was going to be part of one of my questions, because often, so we're from primary care. Patients will show up that will have been to their psychiatrist or Lakeside, things of that sort. And they didn't bring their meds, they don't know what they're taking. And so, sometimes we're at a loss on, what are we going to do? And we'll call, ask for a copy of a list of meds, things of that sort. No, we can't do that. The patient needs to be here to sign.
Yeah, and that's really not right.
Yeah, that happens frequently.
Yeah, and I think that's probably in those situations, what I would propose is maybe having some sort of short educational blurb to send back to them, from the OCR FAQs, it's okay to share this information. And if the patient's there, go ahead and have them sign a quick release, or see if they'll talk to them on the phone, which they may say, well, how do we know that's really the person?
Right.
It's I know, we go around in circles all day long. It's okay, video chat, what do we want to do here? But yeah, that's extremely relevant, and especially if the patient's there and they want you to be able to get that information, because you don't want to prescribe, as the primary care doctor, you don't want to prescribe something that's going to counteract, with some sort of psychotropic medication and stuff.
We also encounter the same barriers with skilled nursing facilities and inpatient rehabs. Meds will have been stopped or changed, and now they're here with us for follow-up. We call over, ask for records. We don't have a release, we can't send that.
Yeah, and I think I'd probably do the same thing with them. It's just it's an educational.
Is there a blank statement like that we could use to fax over?
Probably what I would do is I pulled the OCR FAQs. There is one that's specific to mental health. I think probably I can give you a copy of it, and I would just make copies of that to share. It says, the Office for Civil Rights says that under HIPAA, this is okay to share. And then, to the extent you have the patient there, and here, in addition to that, here's the patient's release saying it's okay.
Right. Which all holds up time and care
It
while
does.
we're doing that. And
It
so
does.
I was so excited about this, talking about what does HIPAA allow for facilities and providers to know you are protected
Yeah.
when we're treating patients.
And the other proactive thing that you may want to do is, to the extent the places that you're trying to get information from have a privacy officer, is to try to go ahead and just reach out to them and maybe just set up a meeting or a phone call and say, hey, kind of on a routine basis, we're asking for this information and we're running into this, and it's interfering with our ability to treat the patient, because we want to make sure that that we're treating them, we're supposed to be all working together. And we can't work together if we can't know what medications they're taking. What do we need to do? Here's the information from the OCR about that, this type of information is allowable for, treatment purposes. Can we do something differently? What sort of process can we set up with you all so that we won't run into hurdles, and we're all doing our part to treat the patient? Because really, at the end of the day, you want to bring it back to the patient. I mean, that's what we're all in this business for, is to make sure that patients are getting the right care. And you can't get the right care if you have no idea what they're taking. So that might be a proactive thing to do, is just to try to reach out to the places that you kind of routinely have problems with and say, hey, would you mind if we come over and sit down? And I would try to do it with either their privacy officer, hopefully they have one, and if not, you want to go to the COO, whoever kind of oversees the operations, to make sure that you're talking with someone in a leadership role that will be able to communicate to frontline staff that this is okay to do, and that the frontline staff will respect what they say and stuff. Because sometimes if you're starting with frontline staff, the default is always, oh my gosh, I've been taught if I do something wrong with HIPAA, I'm going to go to jail. They're going to fine me $100,000. I don't have $100,000. Oh my gosh, I just say no, because then I know I'm not going to get in trouble. And so you need someone who has the ability to say to frontline staff, no, as the organization, we've said this is okay, you can do this and stuff.
Janelle, we have one final question, because time is almost over. But our online, we have from Meredith. It is for an integrated clinic with behavioral health providers practicing with primary care providers that use the same EHR system. Do the behavioral health records need to be locked on the PC providers so the providers can't see the notes?
My initial thought would be no, but when we say notes, it would depend on what the notes are. So if we're talking about notes that would actually meet the definition of psychotherapy notes, which could pull out the definition, but it's notes that are created by the provider related to the specific things told to them during a session with the client, that are made really more for their reference and to jog their memory. I always call it everything that my mother did or said to me when I was little that makes me the way I am today, and oh my gosh, those types of things. Those, in order to qualify to be psychotherapy notes, have to be separate from the rest of the record. So to the extent that you're using an electronic system to store psychotherapy notes, those would have to be locked from the primary care provider. But if when we say notes, we're just talking about general notes. You know, patient Janelle came in today. We adjusted her medication to this dosage. She's coming back again next week for one-on-one therapy, and she's coming on Friday for group. Then no, that's going to be considered part of just the general record, and that does not have to be locked from the primary care provider. And did we have one more question in here that I saw? I think we have 3 minutes. We have time for one more. Okay, fire away. Whatever we can answer in 3 minutes.
Sure. We know that there's a requirement to protect PHI in transit and at rest.
Yes. Mm-hmm.
What if your organization doesn't have the ability to secure PHI in an email format? Are there allowances to accommodate for that?
Okay. So if you don't have encrypted email,
Correct.
then you need to, if you're a covered entity, then I would invest in encrypted email. I'm sorry?
Not my decision.
Yeah, I understand, yeah. I would encourage those that make financial decisions to invest in encrypted email. Other than that, I mean, kind of what I tell people with email and text messaging, because providers, especially those in kind of even hospitals, but ancillary areas where you're having to communicate with lots of different people, text seems to be a very important method of communication. Unless it is an encrypted text, in theory, and unless it's an encrypted email, in theory, it can be picked up. So we know that email goes through multiple servers to get where it goes, and usually a copy of the email sits on all those servers for a period of time that you, the sender, don't control, because it's whoever owns the servers controls that. So anyone who has access to that server can view and retrieve the emails. So what I always tell people is, don't text or email if you don't have secure, but you feel like you need to use unsecured text or email. I wouldn't put anything in the text or email that the patient wouldn't want printed in the newspaper. So, because a lot of people are like, well, if we just use initials, is that okay? It's like, well, not necessarily, because if you're putting a bunch of detail in there, it can be linked back if, people know who that is, especially if it's something that's, say it's related to a car accident that was on the local news, and just because you use initials doesn't mean people won't know who it is. So then we also have a communications issue. We want to make sure that you're talking about the same JB that I'm talking about, because we might be seeing multiple people with JB as their initials. So just be very thoughtful as to what you put in those. Is a risk management tool for now. And then I would work on trying to get, it's not free, but at least look for something that offers a level of encryption. Or the other thing that you can do is, if you have regular, and I'm not the techiest person, but if you have regular senders that you normally send stuff to, I believe there's some ways where you can make sure that you're sending with TLS enabled, which is Transport Layer Security enabled, and make sure they have a system where Transport Layer Security is turned on. As long as it is going with Transport Layer Security, it is supposed to be going in sort of a tunnel. So that would help if you can at least make sure the people you normally communicate with have TLS turned on, and whatever your service you're using has TLS turned on. That's probably the best thing you can do without going with one of the fancy pay services. Now, I don't think there is such a thing like that for text. So text is, but TLS for email will.
Okay, our final question comes from Corey.
I'm going to take us home.
Okay.
Take us home.
So I'm Corey Grant. I'm the Vice President of Operations for QSource. And I really just wanted to thank you, Janelle, for your time and expert guidance today. I personally found it very informative.
Thank you.
And thought you did a really good job of taking a very complex topic and making it actually useful, which we all know is very important for the patient. And, I love the focus on what we can do as opposed to what we can't do, which is how we usually hear about this. So thank you. Again, thank you to all who attended in person and virtually, and to Sharon and the QSource team who worked really hard to put this all together. Took a lot of planning, and I think it went really well. So thank you.
Thank you. Thank you. Thank you to all of our, virtually streaming friends too. Thank you. Is there anything I needed?